Namaste and welcome everyone. So today we are going to discuss the second most popular or nowadays one of the most popular techniques for the breast reduction and lift. So this is known as the vertical pattern with the superomedial pedicle technique. So again, as explained in the previous videos, don't get confused. The vertical is the marking on the skin, hence it is the name of the pattern. Whereas the pedicle that we choose on which the NAC will survive is superomedial in nature. Now if we look at this drawing, we will quickly recall that the landmarks are the most important. So we are going to mark the midline, we are going to mark the meridians of the breast, which are roughly at the mid-clavicular level, and remember they do not pass through the existing NAC, but they are on the lines of where the future nipple areolar complex will be determined. So it is roughly passing through the central portion of the breast, of the final image of the breast. So how is this different from the Weiss pattern or the inferior pedicle that we have discussed previously? So the initial landmarks are going to be same, they are going to be consistent irrespective of the type of technique and the pedicle we choose. So now for this technique, we have chosen the superomedial pedicle and the vertical pattern. Quick important points to remember are that we will mark the level of the IMF, which is joining at the level of both the breast, so that you don't have to again and again lift the breast and see where the existing IMF is. From the midline of the chest, usually till the midline of the breast meridian, this distance is kept constant at 10 centimeter to ensure the future area of the nipple areolar complex as well as symmetry in both the breast after reduction. Initially it was believed that the IMF is a good landmark for the reduction of the breast, but now it has been shown that the upper pole of the breast, where the footprint of the breast begins, is more standardized as compared to the IMF, because the location of the IMF can vary in a lot of individuals and even before and after the reduction. Therefore, we consider the upper pole to be a more standardized landmark. So this is the area where the breast tissue begins on the chest wall, which is just below the level of the pre-axillary fullness. So keeping in mind the upper pole of the breast, the new position of the future nipple will be 10 centimeters from this upper pole, and it will be around 10 centimeter from the midline of the chest. Same thing will be done on the other side as well. The upper border of the areola will be 2 centimeters above the new nipple location. Now in this technique we are not making a Weiss pattern, we are not making the initial pattern which has the limbs that are extending diagonally on both the sides, but we are going to change it to a more vertical approach. Why is that done and what are the advantages? We will see. And ultimately the type of scar that we get is a vertical scar, which ends up to be like a J shape or an L shape, and it does not have the final inverted T appearance. Therefore remember that the vertical pattern refers to the final appearance of the scar or the pattern of the skin resection. So when I was studying this technique, I used to be always confused as to how are we going to know the width of the central area, as well as how do you determine the location and the marking of the limbs. So now the area of the future nipple and the upper border of the NAC are clear as from what we have discussed. So now remember that as a standardized approach, we keep the size of the areola around 4.5 to 5 centimeters in diameter. So considering that as a constant, the circumference of the upper round, which will enclose the future NAC, is roughly found to be 14 centimeters. And if the areola width is around 5 centimeters, this goes up to around 15 centimeters. So that is something that you can just easily remember because that is a standardized measurement. Now, sometimes it is described as a mosque-shaped pattern, but usually what we take is an upper smaller round with a bigger lower round, which gives it the name of a snowman appearance as well. So now that we have determined the upper round, how do we determine the markings of these vertical limbs on the medial and the lateral side? So for this, you have to imagine that once you have made the upper marking, now you hold the breast and you slightly rotate it laterally and upwards, and this marking you have to join it to the meridian of the breast. This will give you the final marking of the medial pillar. Similarly, if you hold the breast tissue and you move it medially and upwards, then from the upper marking to that of the breast meridian at the lower border, you will find the marking of the lateral pillar. This will be more easier to understand when I explain it in another video, but this is the basic concept. So it is roughly a lazy curved marking which is going to join at the level of the IMF in the line of the breast meridian. So there are no specific dimensions of this, but you have to then pinch these two pillars together to see that you are able to achieve a comfortable tension-free closure. Now another important point to remember here is that the resection of your parenchyma. So once you have de-epithelialized the pedicle, you have raised the pedicle, which can be as thin as 1.5 to 2 centimeters. You need not include the whole thickness because that just makes it more bulky and it makes the pedicle difficult to rotate. So it has been proved that keeping it just as thin as 2 centimeter in fact gives it a better vascularity and much easier movement. Once that has been done, the resection of the tissue of the parenchyma itself can be in the Weiss pattern. That means you can excise the parenchyma, the excess breast tissue, even in the horizontal dimensions to reduce the medial and the lateral fullness as per requirement. The vertical markings refer only to the skin pattern. So even if you resect the parenchyma in a Weiss pattern with the horizontal excisions as well, remember that the skin is going to be excised only in a vertical pattern. So if you see it once the breast is lifted up, you will see that this vertical pattern where the medial and the lateral pillars meet along the meridian of the breast tissue have to stop short of 2 to 4 centimeters of the inframammary fold, that is 2 to 4 centimeters above the IMF. We don't put it exactly at the point of the IMF, otherwise when closure is done, this scar tends to lengthen and it will go below the IMF onto the chest wall. So always remember that this has to be stopping above the IMF. So once this closure is done, you will end up with an inverted a J or a L-shaped appearance. So in this technique, it is important to remember that it is the breast parenchymal tissue which is shaping the breast and not the skin. The skin is simply redraping itself over the newly shaped parenchyma, which is the brachytary of the breast tissue. Also in this technique, you should remember that when we mark the level of the new nipple areola complex, it is somewhat lower as compared to what we see in the case of the inferior pedicle technique. Because in this technique, when the closure is done, the NAC tends to rise up even further because the breast tissue pushes it upward, and therefore you might end up with a higher location of the nipple areola complex, that is with the NAC gazing towards the sky as it is called, which is not a desirable outcome in most patients. So that is an important point to remember here as well. A last point here to remember is that if you revise the technique of the inferior pedicle and Weiss pattern, you would have remembered that once we close this area, we have to further make a new opening for the circumference of the NAC. But in the vertical pattern technique, this opening is already present, and once you start closing the tissue, The nipple areolar complex, which has rotated up to its new position, will already have an opening present. So we will quickly recall what are the important points and how it is distinguishing itself from the inferior pedicle and the Weiss pattern. So in this technique, the NAC marking is lower as compared to the Weiss pattern and inferior pedicle, because otherwise the breast tissue tends to ride up, pushing the NAC even further up. The markings of the medial and the lateral pillars where they meet inferiorly has to stop 2 to 4 cm above the IMF. Pedicle as thin as 2 cm is sufficient and helps in better rotation of the pedicle. Shape the parenchyma according to the Weiss pattern if needed, but not the skin. The skin always follows the vertical pattern and the marking. Once you start the closure, a box suture, sort of a A-stitch, is taken to bring the medial and lateral pillars together to reduce the pleating of the skin, which is naturally seen in this technique, and it settles very well over a period of time. Advantages of this technique as determined have been that there is no bottoming out or reduced bottoming out of the breast. It avoids breakdown at the T-junction of the final scar. What about revision? If you have a patient who has undergone a breast reduction previously and you have no idea what technique or what pedicle was used, you can still always safely go in for the superior medial pedicle, because it is always a robust pedicle, and you can always opt for a vertical pattern of closure irrespective of the previous technique that has been used.